Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Erica Bove, obstetrician gynecologist and reproductive endocrinology and infertility specialist. Today's Kevin MD article is A Clinician's Guide to Embryo Grading in IVF. Erica, welcome back to the show.
Thanks so much, Kevin. It's great to be here.
All right, what led you to write this article and tell us what this article is about?
Absolutely. So I'm a reproductive endocrinologist, which means that day in and day out, I help people understand IVF, their results. And part of that is, the quality of the embryos. And what I'm finding is that people come to me with their heads spinning, just not understanding, okay, I have 5 embryos. How does the lab know which one to transfer? How did they rate? Does day 5 versus day 6 matter? And people are really anxious about understanding what I call the alphabet soup of embryo grading. And so I really wanted to make that more accessible to people as they're undergoing the IVF process.
All right, I'm excited to relearn about this too because the last time I learned about this was probably all the way back in medical school, like 30 years ago.
Wow.
So give us a primer in terms of the basics for those who are new to this area.
Absolutely. So one of the big sort of assets of IVF is that we can use the embryos sort of against each other for embryo selection. So when I think about it, it's kind of like which is going to win the race in terms of giving the best chance of a person getting pregnant with that embryo. So we have different methods to look at that. We have an egg and a sperm that come together. And we do this, we retrieve the eggs through a transvaginal egg retrieval. And the lab then sorts through that fluid, picks out the eggs. And then there's two different ways to fertilize those eggs, either conventional insemination, which is like a recipe, mixing the eggs and sperm together. And the second way is called intracytoplasmic sperm injection, or ICSI for short. And that's physically injecting one good sperm into one good egg, right? That's sort of the different way. So the next day after the egg retrieval, the lab looks at what's in the lab and can really see which of those eggs has fertilized.
Hmm.
At that point, right, it goes from two independent cells, ideally, to an organism that has two pronuclei, one from the egg and one from the sperm in terms of the DNA contributions. Those 2PN embryos mean that they are normally fertilized eggs with a diploid set of chromosomes. And then from that point, that's the denominator to look at embryo development. So in our field, we can either do two types of transfers, a day 3 transfer or a day 5 transfer, right? And when we're talking a fresh IVF cycle. So day 3 means that the embryos have divided to the point where they are around 8 cells each. And so we can look at the number of cells on that day, and we can also look at the grading of the cells, how those cells look under the microscope, and then, make our best determination. 8A is like the best that we can get on those days. Although anything, 6 cells, 10 cells can certainly make a baby. We like to see A's and B's in the grade because that sort of helps us understand that the embryos are meeting their milestones and the cells look healthy, right? On day 5, it's actually very different because by that point, thinking of exponential cell growth, the embryos should really be blastocysts by that point, which means they have an outer rim of cells, the part that becomes the placenta, and then this inner cluster of cells, the part that becomes hopefully the baby with fluid in between. And that's called a blastocyst. And so when you look at those gradings, it's actually a much different scale or language. And I'm happy to go into that as well.
So when you're looking at these cells underneath the microscope,
Yep.
tell us some of the things that you're looking for. And is the grading, is it subjective? Are there objective measures? So what are you looking at under the microscope?
Absolutely. So it's interesting, like you can't see all the cells in one plane. So you see, remember, I don't know if you use a microscope on your day-to-day basis. I don't typically, unless I'm in the lab. You kind of zoom in and out to look at the different cells. And so you can count the number of cells in this day 3 embryo. And ideally you want to see 8 cells because the embryo goes from 2 cells, right? We talked about that before. And then there's the mitotic divisions, and then 4 cells, and then 8 cells. So those are very symmetric cell divisions,
Hmm.
and then even numbers, which we like to see. So you can look and truly count the number of cells. And then from the qualitative appearance of the cells, you want to see cells that are whole, circular, not fragmented. Sometimes you can see these little granules. It almost looks like the cells are degenerating. And so you want to see these nice, crisp, round structures that are the cells. And then, as we know, these cells then end up differentiating. But that's a very nice structure is, ideally 8 cells without self fragmentation. And then each cell looks very cohesive. nice even numbers. Now, to your point about the subjectivity, I would say it's a lot easier to grade a day 3 embryo with less subjectivity compared to day 5 because there's more parameters. But in general, I mean, nobody's going to argue with the number of cells that are counted for the most part. But then I think that cellular fragmentation, is it an A? Is it a B? I will tell you, in my lab, we have even more distinctions. Again, that's where that subjectivity comes in. There's an 8B plus, which is almost an 8A, but not quite an AA. We have an 8B minus. And then when you get into like C's and D's, that's when we're talking about, a lot less cell cohesion and fragmentation.
What are some of the variables that affect the viability or grade of an embryo?
Yeah, absolutely. So maternal age still seems to be the most important predictor of egg quality. So it's super fascinating. If you look at like a 40-year-old woman and you look at, say, she even makes 5 or 6 blastocysts, then we know that like 80% of those blastocysts will be abnormal. But if you look at somebody who's, say, 32, roughly about half or maybe even up to 60% of those blastocysts will be normal on the chromosomal level. And so certainly egg quality and which is related to age is the most important predictor of that. And then also sperm quality is interesting. If it's a sperm issue, we will often see good day 3 quality because the male genome is not even turned on until day 3. So you might see poor day 3 to day 5 progression. That suggests more of a male etiology, but it can be really hard to tell. Other variables that can affect egg quality, endometriosis does seem to play a role in egg quality, where even younger women can have worse egg quality. Same thing with polycystic ovarian syndrome. That can really have an effect on egg quality. Also, even obesity, it's controversial, but there are some data that women who have higher BMIs do have worse egg quality, and that can impair embryo progression.
Now, how do you transmit all this information about the egg quality to the patient?
That's a great question. So when I see a patient, so first of all, we decide if a patient is wanting a fresh transfer, because there's some people who actually want a frozen embryo transfer. Typically, we're talking about a blastocyst that's frozen. So if we're talking about a fresh embryo transfer, I'll look and see how many eggs fertilized, and I'll look at their age and say, okay, are we more likely to do a day 3 embryo transfer or a day 5 embryo transfer? And so on day 3, what I'll say is, okay, if there are 1 or 2 embryos that are really clearly ahead of the rest in the pack, and the others look like they're much worse quality, then we're going to be able to choose which embryos to put in. And the American Society of Reproductive Medicine does have a very clear guideline of how many embryos to put in under different circumstances. We're doing a lot more single embryo transfers because if we put in 2 and they both take, the risk of twin pregnancies are higher. And so really saying, okay, this is how many eggs you had. This is how many fertilized. That, I go through, these are the number grades and the letter grades. This is how we'd rank your embryos. And based on your age of 39 and your diagnosis, we recommend putting in 2 day 3 embryos. Is everybody in agreement with that? And I go through, these are your success rates for you, your age, your diagnosis. This is the twin rate. If we put in 2, there's always a very, very small chance that one of those embryos will split. And then, if everybody's in agreement, then we move forward. Now, there are patients who say, my worst nightmare is twins for various reasons, right? Like maybe people already have children at home or they're a single parent. Again, everyone's situation is different, but we tailor the number. We look at the recommendations, and then we tailor our, recommendation based on their situation and their desires.
Wow, so it's very numbers based, obviously. So what will be a common scenario just to kind of give these numbers to life?
Oh, yeah, absolutely. Okay. So say there is a 36-year-old woman with male factor infertility, and we get, say, 15 eggs from her on the day of the egg retrieval. I always say that not every egg is mature, and only mature eggs can be fertilized by sperm. So say we get 15 eggs, say 12 are mature, say 10 fertilize with the ICSI technique that we talked about. And then I would say we can expect probably anywhere between 3 and 5 blastocysts from that cycle. So somebody who's good prognosis like that, still relatively young, male factor IVF can exist to bypass that, traversing of the sperm up into the reproductive tract. That person has a pretty good prognosis. And so, I would recommend typically that we'd look at the day 3 embryos, but if they were all kind of neck and neck for the most part, then we would then grow those embryos out to day 5, day 6, and then say, okay, this is what you've got. We typically will do a transfer on day 5, and just to share a little bit about the grading. So it's a much different scale. By this point, you can actually see the embryos in the dish with the naked eye. They're very small, but you can see a little speck. They've got 80 to 100 cells. Obviously those exponential cell divisions have taken hold, and so typically we grade the embryos stage 1 through stage 6. Stage 1 and 2 are very kind of small blastocysts. You can't really distinguish that outer rim of cells called the trophectoderm with the placenta layer from the inner cell mass, which is that cluster of cells that becomes hopefully the baby, right? So stage 1, stage 2, still very early blastocysts, although we can transfer them sometimes with good rates. And then stage 3, 4, 5, 6, that means that the blastocyst is in various stages of expansion. And so as I like to say this to patients, blastocysts are really looking for a home, right? They're trying to find the uterine wall, the endometrium, and invade into the maternal vasculature, because that's how they'll continue to get the nutrients for their continued development. So stage 3 is like still, you can see those layers, but it's still kind of compact. Stage 4 is you can see the blastocyst starting to expand. 5 is hatching, right? You can really start to see the embryo itself hatching out of that outer layer, and then 6 is fully hatched. And so, one is not necessarily better than another, but I like to help my patients understand like where we're at. So say, we get to day 5 and this woman that we talked about has a 4AA embryo, and say she has maybe 3 or 4 other really strong candidates as well. 4AA is a gorgeous, embryo. It means that the first letter represents the inner cell mass, which is hopefully the baby part, right? So that's an A. Say the outer rim of cells, the part that becomes the placenta, that's an A. That's a beautiful embryo for transfer. Now, we might then freeze, 3 or 4 high quality embryos after transferring the one, hoping she gets pregnant with that embryo. And then, all those other embryos that are frozen have about a 50% chance each of success. So, the tricky part is you can go from, a whole cycle where you get 15 eggs. Not every egg's mature. Not every mature egg fertilizes. About 70 to 80% is typical. And then even in young patients with a good prognosis, even a 50% blast conversion rate from the 2PN stage to the blastocyst, that's a good blastocyst conversion. In older women, it can be even higher. And so I try to say, obviously I only want my patients to have one egg retrieval if possible, but we want to maximize what we can. And for that 36-year-old, she's probably got a couple kids in that cycle, but maybe not. If they wanted a third kid, they might need to go back to the drawing board and do another cycle. Yeah. Is that helpful?
So it sounds like an overwhelming amount of information. I could only imagine
Yes.
for the patients and
Yes.
their families as well. So
Yes.
how do you guide them through that? Because these are obviously life-altering decisions, a lot of numbers,
Mm,
a lot of layers of grading. How
yeah.
do you guide patients through that decision-making process?
Sure. I think one of the biggest things is you have to know the patient and you have to know their history. And it's a little tricky because sometimes I'm doing a transfer for my partner's patient and I may not know them intimately in terms of knowing their values and their goals and their desires. And so I make sure I always read the chart, thoroughly ahead of time. So I really understand, okay, do they have a unicorn uterus? Should we really only be thinking about one transfer? Do they have a history of preterm delivery? I'm definitely less likely to put in more embryos. So, for me as the clinician, I really want to have a good understanding of that patient going in. And then I then explain to them the embryo grading, either day 3 or day 5, say, this is what you have. And this is how I break it down, Kevin. I say, if you were my sister, this is what I'd recommend, because I find that, we've sort of gone away from some of the paternalism in medicine, but I almost think we've swung in the other direction in terms of like, choose anything, it's all going to be okay. And so I find that patients want some direction. So I might say, hey, if you're my sister, I'd really think about putting in 2 embryos. Maybe the quality isn't so great. So I think the risk of twins in your situation is going to be like less than 10%.
Yeah.
But if that's your worst nightmare, then let's only consider one. And we have that conversation in real time. Sometimes I even like take a step back, go back into the fishbowl, like I call it, where I sit and do my charting, and then come back after the couple has had a chance to really talk among themselves about their goals and their values and everything. I mean, cost comes into play too. It's a lot less expensive to put in 2 embryos than to keep paying for storage and all those things. But again, we really don't, we want to minimize the risk of twin and triplet gestation, which can certainly happen the more embryos we put in. So it's a very nuanced conversation. And I think we have to sort of take everything into consideration.
So simplifying it down, is there an overall correlation rate? And I know this is really, really reductionist between the quality of embryos and the success of having a baby. So
Yes.
what are
Yeah.
what just give us some context in terms of what that correlation is in terms of percentages.
Yeah, absolutely. So say you have like an 8A embryo and it's a good prognosis patient. that embryo can have a 40 to 50% chance of taking because it's
Okay.
a high quality embryo. But if you're looking, say it's like a 6B embryo, that embryo, and I'm throwing out numbers, I need to see the chart, but like say roughly like a 20 to 25%
Okay.
chance of taking because it's lower quality. And then you can also look at, okay, if we put in 2 embryos at once, what is your chance of a successful outcome going to be? Roughly speaking, with high quality embryos, if you put 2 in at once, it gives about a 10% increase advantage to the success of that transfer. So maybe it goes from 40 to 50% or something like that. But you also have to say, well, then there's a 25% chance of having twins. And if we were to put in 1 embryo, keep that other embryo frozen, return in a different cycle, you'd probably have an even higher cumulative pregnancy rate after 2 transfers. And so I go through the numbers and say, okay, your highest chance of 1 healthy baby at a time is to do this, whatever it is. It may be 1 embryo, it may be 2 embryos, but really looking at the quality and the numbers. Blastocysts, it's a little bit easier. I think that blastocysts are at such a farther stage of development, and really a lot of milestones have to be reached between day 3 and day 5, that the blastocyst success rates are a lot higher. So, if you have a blastocyst, now we're talking frozen embryo transfer, but say we've tested the chromosomes, that embryo can have a 65 to 70% chance of taking, which is far higher than anything outside of natural conception. And we really only put in 1 tested embryo at a time when we have that information. And so I think what I think about this is like, it's a lot of tools that we have at our disposal. Making it accessible for patients is like in the context of their situation. We use the ASRM guidance, but I think at the end of the day, it really is a nuanced conversation between the patient and the doctor.
We're on Erica Bove, obstetrician gynecologist and reproductive endocrinology and infertility specialist. Today's Kevin MD article is A Clinician's Guide to Embryo Grading in IVF. Erica, let's have some take-home messages they want to leave with the Kevin MD audience.
Sure. So one thing I would say is some people go from clinic to clinic, say things don't pan out at one clinic, they still have embryos frozen and they go to a different clinic. Not all the grading is the same clinic to clinic, and every clinic has their own success rate. So it's a really important question to ask. Like, some clinics rate embryos a grade D. So I was always used to that in my career. And then I went to a place where the sort of the lowest grade they gave was a C. And so then I had to readjust my brain to be like, okay, well, a C in this system is actually a D in my previous system. And some clinics have, I wish there was one true standard, but there's not. And so really understanding clinic specific success rates, whether it's day 5 versus day 6, those are really, really important questions to ask your REI and your lab staff, for your own clinic, but then especially if you change clinics and are used to a different, if you're switching clinics and you're used to something else, make sure that you're really comparing apples to apples. So I would say that. And I would always say, I think as patients, we really do want to empower ourselves with the information. I really trust my embryology team, even as a physician, to help me make these decisions. Because sometimes, say you have 2 4AAs that are graded that way, but maybe the lab sees something different. Maybe one's expanding versus not as rapid expansion. These are dynamic processes. And so really trusting the lab staff, because that's what they do. They are embryology. That is what they are trained to do. Sometimes they'll grab me and say, hey, look under the microscope. Do you see this? But really leaning on your clinic to help you understand like which embryos to transfer and in which order, I think that can be really helpful. Now, there are tools out there called Embryoscopes. I want to just give a brief word on that. That's where you have like 24/7 capturing of the data where you watch the cells divide in real time. Obviously, slow process, but you can sort of see if there's chaotic divisions and all those things. Those all sound really great on paper, but they have not been shown to improve outcomes, and they're really expensive. They add cost to patient care. So, I would love to put stock in those and to say that, oh, this technology is going to help us, but I don't think we're really there. And so as of right now in 2026, it really is, looking at trusting your lab, looking at their individual success rates, and then leaning on your team to help you decide how best to move forward.
Erica, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Thanks, Kevin. I appreciate you.